All right, can everybody hear me? Air conditioning too loud? At least we have air conditioning. So you made it to cardiology, which is kind of a paramount area for paramedicine. This would be where I need you to dial it in. If I have any of you that are lost, it'll be at this point in time. For some people, cardiology comes absolutely naturally. For some people, it's the hardest part of paramedic school. It's normally the crucible part. So if you have any questions, make sure that you are asking them. We're getting to the root of whatever misunderstanding you're having, because cardiology is not something you can mail in. This is a very active part of paramedicine, with a lot of our calls coming from a cardiological standpoint. So most of the time I leave a lot of your lectures alone. This is one of those times where I've customized and gave you a lot more information. Several books went into creating this lecture or lecture series. We're looking at about 552 slides worth of books, material, things I've written, things I've stole, borrowed, bought. So that's where we're at with all that. So what percentage of calls do you think you run in your service area that do you think are cardiological in nature? I can't hear you. So we're looking around between service areas in Georgia. If we look at your call data and actual cardiac calls, you're looking at somewhere between 48 and 55% of the calls being cardiac in nature. Why do you think that is? Bojangles. Damn you. Chest pain. So with us confirming cardiac events, we lack the ability. With that, let's say I am a paramedic that can read an EKG, but I want to caution you now that your chest pain patients, only about 40–45% of them will have EKG changes when they're having a myocardial event. Let's run that back. Your chest pain patient that is having a heart attack, an MI, only 40–45% of them will show EKG changes. That's called a STEMI, ST elevation myocardial infarction. The non-STEMIs take up the bulk of the myocardial infarctions that occur. They take up the bulk of them. Now, why do we see STEMIs appear? Well, water, air, electricity always takes the path of least resistance. That change in the EKG is the electricity hitting an area of dead tissue and trying to find a way around it. So I can't rely on an EKG to tell me if somebody's having a heart attack. What if they've got all the associated signs and symptoms? Substernal chest pain radiates to their left arm. They're nauseous. Their jaw's starting to hurt. They got a history of heart disease, diabetes, hypertension, renal disease, the big three, really. Even then, I can't say for sure they're having an MI because there exists costochondritis, left ventricular hypertrophy. Many other things can cause a chest pain patient to have chest pain. And there's also a group of people that don't even have chest pain when they're having an MI. Women, elderly, diabetics, they have autonomic dysfunction where they won't even have chest pain. They'll have what there's called silent MIs, or they'll feel weak or tired or even have difficulty breathing or even describe it as back pain. Everybody remember Dr. Waterman? The old medical director? I really enjoyed Dr. Waterman, but he came into AMC Maine one night, the ER, Still a little weak, didn't even have chest pain. The other doctor put him on a 12 lead and found he was having a STEMI. So this is why I want to encourage you to 12 lead everybody. I have found little old ladies like, I just feel weak today, baby. And I put her on the 12 lead, and there it is, a big, beautiful MI. But again, I can't play God with patients by saying yes or no, they're having a MI based on my just EKG. The only way to really tell is to do a blood test and look for their elevated troponin levels. So any of you out there trying to play medic paragod, note that sometimes your patients won't have chest pain. Sometimes they won't have EKG changes. Sometimes they'll present in a different manner. Have you ever seen a paramedic make a decision on scene to invalidate a patient because their EKG was clean, or because they were a homeless person, or because they just didn't seem to meet the right criteria that they were taught? I'm cautioning you against that. If the boy cries wolf, act like there's a wolf there until it is clear through blood tests that there is no wolf. Because otherwise, the wolf will sneak up on you and bite you. Now, I know that's a metaphor, but what I'm saying is a patient and you can suffer damage and harm because you weren't ready. Best way to get ready is to stay ready, right? Treat every patient from start to finish with new eyes. I mentioned the story of old homeless Joe, right? I picked him up all the time for chest pain. And for every time he called for chest pain, I treated him for chest pain. 12 lead, I'd stick him with an IV. Blood pressure was high anyway. I gave him some nitro. But I'm working backwards from the conclusion that he actually is having an MI. Most of the time, he wasn't. 1 out of 10 times, he actually was. And because of me not discounting him, I caught it. So we're saying that it's a high call volume area for us, right? A high call volume area for us. And because it's such a high call volume area, we must put a lot of premise and respect on this by making sure we know our stuff. This is one of those areas that separates you from the animal that's in EMT, is knowing how to read an EKG and treat cardiological events. We're kind of spoiled here in the city, right? 20 minutes in either direction, you're in a level 1 trauma hospital, cardiology center. But think about if you go work somewhere else or you pick up a side hustle, you might be an hour from a cardiologist, which means you're now the cardiologist. You've got to be able to interpret, understand, recognize signs and symptoms of cardiological events. And we're not just talking about heart attacks. We're talking about cardiomyopathy, pericarditis, hypertensive issues, stroke. How about AAAs? All of these types of issues you have to recognize, be able to treat. How about EKG abnormalities such as a heart rate that's too fast to be conducive with life? Because again, cardiac output is what? Heart rate times stroke volume. If your heart's too fast, it will reduce stroke volume. If your heart's too slow, there's no way it can meet the metabolic demand of your body. A lot of paramedicing is treating heart rates that are too fast or too slow, or treating a pressure issue by constricting the vascular bed with vasoactive substances, medications that are alpha constrictors. Or by doing what else? Treating an ectopy problem, such as if a patient's got a problem with a errant pacemaker cell that has too much automaticity, I would suppress it with an antiarrhythmic. Give you an example would be, we talked about lidocaine in pharmacology, right? Lidocaine suppresses automaticity of the ventricles, meaning if I have a electrical pacemaker cell that's misfiring, I will suppress its ability to create electricity. There's a lot going on at stake here. More than 60 million Americans have heart disease. A good chunk of our calls are cardiac in nature. The numbers I saw when I was in paramedic school 15 years ago were about 400,000 people per year die of heart disease. That number is 850,000 now in America. We've more than doubled in 15 years. Why? Bojangles. AFC. What else? I was at the barbecue place last night, clogging these arteries with ribs. Exactly. So we have sedentary lifestyles. We got all these work from home jobs now, people sitting on the rear end. And of course, we have poor food choices. But it's not always the food choices, it's also what's in the food. This is the single largest killer of Americans. Your job is to recognize the signs and symptoms and aggressively treat them. What do I mean by aggressively, fan? We're not hesitating. Do something. Even if it's wrong, you need to do something, make a decision, and go with it. Every decision you make on the EMS call or the fire ground is one you have to defend, right? It's easily defensible if I say I saw this, made this decision. That's critical thinking. Because what you did was you cornered the bull. Where I'm from in South Georgia, if you've ever had to move cattle to a certain place, we would corral them, right? By eliminating answer choices. The cow has no place to go but to this one corridor that I've created. I've corralled it. You're going to corral yourself by eliminating possibilities through your assessment and through a patient's history, a physical exam. You're going to corral yourself to only a limited number of possibilities. That way you can actually formulate a field diagnosis and treat your patients appropriately. Now, what are some other things that can cause cardiovascular disease? How about smoking and crack? Hell yeah. Smoking cigarettes is a proven risk factor. Cocaine use can cause cardiovascular disease. Older age. Yes, I'm looking at you, Randy. What about family history? Does it have a precipitating factor? Yes. If Peepaw had a heart attack and died, and so did Daddy and uncle number 2, there's a possibility that you will have a higher percentage chance of having that happen. Now, that doesn't have to be your story, obviously. You can impact that by what? Get up and move. Eat a little bit better. Take those risk factors out of the equation by deciding not to smoke, not doing cocaine. Fan. How about hypertension? Can I control blood pressure? Yes, I can take medication. I can lose weight. Hypercholesterolemia. I can take Lipitor. I can eat less fatty foods. And I hate to say it, but I can eat a whole foods diet and or a more plant-based diet and reduce those numbers. I'm not pushing anything on anybody, but I dropped 100 points on my cholesterol numbers by switching to a plant-based diet for a few months. Once they were where I wanted them, I went back to the meat. Amen. I'm back, baby. Family history. Yeah, the medication only helps a little bit. So what he's saying is, and again, I'm repeating it because I'm recording it for people online. Family history gives you a higher chance of having a certain disease process, and medication only impacts that reduction in harms percentage chance by about 20%. Lifestyle changes, 80% reduction in chances. That's a fact you can Google. I think Dr. Danielle Bellardio, a cardiologist in Houston, has those figures and studies. What about carbohydrate intolerance? I personally, even though you can't tell right now, do very well on just a protein and fruit and vegetable diet, because anytime I even smell a carb, I bloat. I'm intolerant to carbohydrates. Being of male gender. That's right, boys. Sucks to be you. Except for Grim. You got lots of estrogen. Whoa. Too far?
Yeah, I did not see that at all.
You didn't see that coming?
I was very masculine.
You should have felt masculine. You be you. How about a lack of exercise? A lot of us make excuses, especially if we're in paramedic school. Right? Well, that's what happened. I got to study. I'm tired. Whang. It's I don't know what you'd call it, but it's kind of like the freshman 15. When you first start college, you start gaining weight. I guarantee you the majority of paramedic students that I know throughout all the years have gained at least 10 to 15 pounds throughout paramedic school. Now, again, that's because they're not active as they were. Now, there's some people that keep a regiment and they strict with it. I myself gained 25 pounds in paramedic school. But that was also because the lunch ladies at Albany State had that biscuit and gravy special with sausage, eggs, and a Mountain Dew. So 4 days out of the week, that was my breakfast. That was not a healthy choice. But damn, was it good? And they love me. They had it. Yeah, baby, you like need extra scoop. I flirted with them. I did what I had to do. So we can't impact these things, and we can't impact our patients. Now, we're not trying to come from a place of a high horse, like you fat bastard, lose some weight, you know? But like that teachable moment is exactly that. Hey, Mr. Fain, if you don't want me to come back out here, you know, and you're having these chest pain or these cardiology problems, man, you some small changes, you know, just eat the grilled chicken versus the baked, you know, small things like that can make a big impact. So I found my baby picture. You want to see it? That's me. Or could have been. So other factors that can increase risk are the diet and obesity rates. Stress can do it. Being in paramedic school is stressful. It could kill you. So diet, obesity, oral contraceptives. Oral contraceptives make you more at risk for what? Clots. And psychosocial tensions like stress. Stress kills, Woody. Birth control pills. It affects hormones in a woman's body. Yeah, it flips the script on them because it's not a natural occurring process, right? We're influencing them by having bioidentical hormones adjustments in them. So instead of having a period every month, correct me if I'm wrong, but they'll have one every couple months, right? So we're making them hold on to things. So yes. So it puts them at greater risk for clots. It used to be a old adage, like an old question you used to get would be, you got a woman that can't breathe, her lung sounds are clear, but her history is she's a smoker and she's on birth control. What happened? She had a PE. That was a very common question a few years ago that they used to test people on. So stress can kill you. Learn to de-stress. Now, there's some things you can't prevent, right? You're in school right now, and you're obviously more stressed than you were before. You got deadlines, right? You got homework, you got work life, you got to balance it all. Sometimes even I myself like drop the ball. But that's okay to drop the ball. You just have to pick it back up again. 7 times will a righteous man fall. He'll get back up 8, right, Woody? We just have to pick the ball up and keep going. So stress will get you. One more slide and we'll take a quick commercial break. So ways you can impact this is public education. One of the pillars of a successful EMS system is getting out there and teaching people about risk factors, about prevention strategies. This can also impact your call volume. by having a better educated patient population. Do you think a more educated population votes better because they know what they're voting for? Loaded question, I know. Do you think a more educated population makes better health decisions? A few of them will, maybe. I didn't say all of them, because there's people that know exactly what to do, that choose to eat a bacon, egg, and cheese sandwich after they had swore they were going to fast this morning. But no, thank you. I appreciate the sandwich. +5, obviously. That was the Lord's way of telling me don't fast. You good. No need. So teaching symptoms of heart attacks, adult education like CPR training, prevention strategies and education. We have to give back to these communities, because if you are educating the community, it will impact your call volume and the amount of work you have to do. One last figure, and we'll take a quick commercial break. Bystander CPR increases the chance of somebody surviving by 47%. If I could give your loved one a 1% chance of living, would you want it? Of course you would. 47%. That is a fact that you can find from American Heart Association's data. It's a journal called Circulation. Huh? Quality bystander CPR. Yes, quality. Quality CPR saves lives, though. And if you teach them how to do quality CPR, think about how much easier your job would be if when you got there, if you didn't have to start from nothing. There's phases to a cardiac arrest: electrical, circulatory, and metabolic phase. If you've got somebody doing quality CPR, you have been saving tissues. You have been keeping those heart cells viable for longer. I like it. So I want you to know that all body tissues require oxygen to survive. Circulation. You must have a strong working pump, intact pipes, and obviously the blood volume has to be enough to meet the demands of the body. But there also has to be the right stuff in the blood, an adequate amount of hemoglobin. Why do you think that is? Woody? Yeah. That's right. So it can carry oxygen components around. Very good. So this can be impacted by a poor working pump, by a lack of blood volume, or lack of molecular components that are carrying the right stuff, right? Nutrients. The heart is located in the chest, as we've all seen from Dracula movies, right? But it's not right in the center like we've been told. It is greater 2/3 of it's on the chest, on the left side. Greater 2/3 of it's on the left side. Unless you have a condition called dextrocardia, where it's on the right side. We're saying this is a muscular cone-shaped organ. Now, what does it mean to be cone-shaped? Like it forms a point, right? Everybody saw that Madonna movie, right? Cone. There you go. Don't cry for me, Argentina. Y'all paid for this. Remember that. So it's about the size of your closed fist. There are conditions, though, that can enlarge a heart. Things that can make left ventricular hypertrophy. A good example of that is somebody with uncontrolled hypertension. How would that make the heart bigger? Well, if you push, there you go. If you have a greater resistance, it'll make the muscle hypertrophy and strengthen, right? Some of y'all, I can tell, don't know anything about that. Hypertrophying muscles, pushing heavy weights. So we have layers to the heart, donkey. We've got layers. Innermost layer of the heart, we're going to call the what? Endocardium, because it's endo. What about the next layer, the muscle itself? Myocardium. After that, we have the epicardium. Epi meaning outside and around. That's all surrounded by a pericardial sac. Pericardial sac. So that pericardium is a thick, fibrous membrane that surrounds the heart. helps to anchor the heart, which means it doesn't let it fly off into the distance. Also prevents over distension. Can your heart overexpand and blow up? Without a pericardial sac, it can. And even still, there are conditions and times and places where the heart just explodes. Let's talk about a ventricular aneurysm. So, a weakened wall of the ventricle does what? Literally explodes. What kind of condition can a patient get where the sac is full of fluid and it's killing them? A tamponade. While we're on the subject of the sac, I wanted to bring it up. This is a buildup of blood and other fluid in the pericardial sac, putting pressure on the heart. It can happen very quickly. This is a form of obstructive shock. Why is it obstructive? It's blocking it. Blocking it. Same thing would happen if me and Isaac went and played basketball, right? He would try and use them old knees and try and get around me and shoot a ball, wouldn't he? But I'd block it. It'd be nasty. Not in my house. No, no, no. So we would have a tamponade for him. Best thing you can do for that is what? Hospital. They need a pericardial centesis. But if we remember Starlin's law, that if to a point, if I increase preload, I can increase contractility. I can give a small fluid bolus to a tamponade, let's say like 5 mLs per kg. And what I can do with that is increase that contractility for a little while and help augment the blood pressure. This only buys you a little bit of time, but it does buy time. They need a centesis. Other signs of tamponade would be Beck's triad and electrical alternans. Let's take a look. Hypotension, JVD, and muffled heart tones. Hypotension, JVD, and a muffled heart tones. Honestly, most of us don't even have a good enough stethoscope to hear anything. You know, think about it right now. Like, I'm struggling to hear what you even just said right here. And it's just because we have this giant AC in here blowing on me. Think about on the side of 75 cars going by. Heart tones are hard to hear, but what you can get good at is listening to normal sounds and find out what abnormal sounds like by knowing that it's not normal. One of the best ways we can tell if a patient's having a tamponade or we suspect it is mechanism of injury. I pull up and the steering wheel's bent. He's got some kind of chest problem going on. He's got JVD. Lung sounds are clear. Sats are good. I mean, I don't want to confuse it with a tension pneumo. What's the differentiating factor? He's got good lung sounds. Sats are good, right? What'd you say, Fan? There you go. Now, alternans, I'll talk more about this later. I just want to get it in your brain right now. But if you have a patient with electrical alternans where there's different heights going on there, the electrical current's alternating, it's usually a sign of a tamponade. And that is a very tall tale registry thing to do, is to give you a electrical alternans rhythm and all the other signs and symptoms and ask you to identify what's going on. So the structures of the heart are divided into 4 quadrants. The 2 top chambers are called atria. They receive blood from outside of the heart. They're divided by the intra-atrial septum. Inter meaning inside, atrial meaning it's the top part of the heart's chambers, and septum is to divide left from right. Now the ventricles, back, are the 2 lower chambers of the heart. These are bigger and more muscular. These are going to be pumping blood outside of the heart. The right ventricle pumping blood into the lungs, the left ventricle pumping blood throughout the rest of the entire myocardium. They're divided by an interventricular septum. Now, why do you think we have a septum divide left from right? Very good. Keep the oxygenated from the unoxygenated. So, septum, we said what that is. AV valves. The heart has 4 valves: tricuspid, the pulmonic, the mitral, and the aortic. Remember the toilet paper, my anus. TPMA. Tricuspid, pulmonic, mitral, aortic. So the valves that are AV valves are the ones that literally sit between the atrium ventricles. That'll be your tricuspid and your mitral valves. Semilunar valves are located between the ventricles and the arteries. These guys are semilunar valves because why? Of their shape. Of their shape. So the chordae tendineae, small muscular strands that attach the ventricles to the valves, connected by papillary muscles. These guys actually pull the heart apart and let it slam together and contract. Pull it apart, contract. Pull it apart, contract. So the term heartstrings is where this comes from. Take a quick break right here and talk about this picture. Not a break from the lecture, but let's just pause from cardiology and understand what this thing's saying to us. I like Paul Combs' work. He does a lot of caricatures and drawings. I think he works for some fire department like in New York, New Jersey, Boston area, or something like that. And he does these as educational pieces. Now, what is this telling me as a paramedic student, Grim?
It's saying that this your experience in you always have to take training for what you have to do.
Very good. My experience alone cannot save me. My equipment, as fancy as it is, which none of you have the right to say that in this room, can save you. Only thing that can help you is to have continued training in fire, EMS, rescue, hazmat, operations, continuously staying and working towards this. Experience without theory is blind. And all theory with no experience is just intellectual wordplay. Experience without theory is blind. You can have all the experience in the world, but let's take old man firefighter, put him in this new hopped up building with all these building codes, and let's say a bunch of computers catch fire. Let's say a bunch of electronics catch fire, and it's the systems in the building start releasing, what is that stuff? Halogen. He's not prepared or understands to know the nuances of what that gas can do to him, right? Because he hasn't stayed up to date. He's got all the experience, but he doesn't have the theoretical application of this new material. Now think about brand new firefighter recruit. I have a bachelor's in biology, man. He's also went ahead and went straight to paramedic school. He's got all the theoretical workings, right? But he has no experience. He's never touched the door and been burned by it. He doesn't know to tap down the hallway or he'll fall through a floor. He's never made a push down that way. He could get hurt, right? Because he has no experience. It takes all of it to be a successful provider. And honestly, the smartest you'll be as a paramedic is right out of paramedic school. The most dangerous you'll be is right out of paramedic school. After a couple of years on the road, you'll start to develop what we call that sweet spot, to where you have experience, You understand the theoretical workings of the pathophysiology, pharmacology, cardiology, and airway management, and things are firing on all cylinders. It's going to make a lot of tactical errors in the beginning. Keep that in mind for me. So the heart sounds are characteristic of normal blood flow. The lub, the dub. S1 is the closure of the AV valves. The AV valves being the tricuspid and the mitral valves. The dub, or the second heart tone, doop, 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 lub, dub, lub, dub. The dub part is what? That's the closure of the semilunar valves. That is those second ones. Those are the normal sounds to have. If you listen to a patient's heart tones and they have neither, it's usually a bad sign that you should start compressions. Or you need a better stethoscope, or you're deaf. Lots of variables there. What about an S3 sound? This is known as the gallop. An S3 sound is normal in very healthy individuals. We're talking about like Usain Bolt, Lance Armstrong, me, these people that are in incredible shape. Hey, round is a shape. I'm a circle. Some people like it. Anyway, but these individuals have a normal tone. This is the guy with the heart rate of normally that's 40, but he also runs marathons every day. You get me? Talking about some David Goggins stuff. But S3 in the normal individual is an abnormal sound. Lub dub, lub dub, lub dub is normal. But the S3 is, it's called the gallop. The ventricles are starting to stiffen. And what you're hearing is a sudden deceleration in blood flow. It's causing a sudden stop in that blood flow because the ventricles are starting to stiffen. And it's starting to be a sign of reduced ventricular contractile capability. So stroke volume's falling. If you hear S3, majority of the time, it is a sign of CHF. That is a test question I have seen on the National Registry. If you have a patient with S3, it is usually a sign of CHF. Healthy people like me and Lance Armstrong, normal. But S3 and the rest of y'all, heart failure. So S4 is a sound that actually comes before lub dub. It's like blank, lub dub, blank, lub dub, blank, lub dub. That is again another sign of stiffness of the left ventricle, scar tissue formation, coronary artery disease, and aortic stenosis occurring. The heart's having trouble getting the blood out because the tissues are narrowing. And that turbulent sound is created by a narrowing of the opening of the lumen for blood to flow through. Now, some other honorable mentions for the heart tones and sounds are murmurs. A murmur, a bruit, a click, and a snap. A murmur sounds a lot like a muffling. Like they have an extra sound that sounds like a muffled little tone. A bruit sounds like water going over a river rock or turbulent blood flow that's meeting resistance. A click and a snap really is that. Click, snap, click, snap. That is because of the valves are having some issues there. They're having some valvular issues. They're not completely closing at all. So, who wants to draw the path of blood through the heart? Yay! I'm gonna go ahead and move the board over and let you do it. Can we go back? S4 is stiffening aorta.
So I always think the number of topics would be that we're going to have it where the food happens elsewhere.
You can. There's a lot of different causes for one. You know, some people are born with one, some people develop one, some people have a traumatic event that causes one, you know, so it really depends on the etiology and origin of that said murmur. You ready? Draw them in. You can do it on the board over there.
Right. I mean,
All right, that's good. What we're saying is that we're gonna have blood come back to the right atrium via superior, inferior vena cava, and coronary sinus. Blood will then flow from the right atrium through the tricuspid valve into the right ventricle. Right ventricle will shoot it into the pulmonary artery via the pulmonary valve. Lungs will oxygenate that blood and then send it back to the left atrium. Atrium then will push it through the mitral valve into the left ventricle, and the left ventricle will pump it throughout the rest of the body systemically. Let's see if we can finish it. I like it. All right, how'd it do? Yeah, okay, thank you. All right, everybody see it?
like.
Yeah, I thought he would draw it too, but he didn't. So the heart's a muscle, right? It's tissue, right? It has to be fed blood flow and oxygen, right? Who gives it to it? Yourself. The coronary arteries feed the heart. They branch right off of the aorta. So the first structure the heart feeds is itself. There's a lesson in there. I told somebody this yesterday, is that you can't pour from an empty cup, buddy. You need to start doing what's good for you so you can do what's good for other people. The heart's giving you that lesson that it feeds itself first. You've all been on an airplane. If we've experienced an emergency, put your mask on first, then help others. The lesson is that, again, you can't pour from an empty cup. The heart's giving us that lesson. So we have several coronary arteries that feed the myocardial tissue. Now, the ones we mainly talk about are the right coronary artery, left main coronary artery that branches at this fork in the road right here into the left anterior descending and the left circumflex. So the left main has that fork in the road. Sometimes people get a clot right there at the fork in the road. This is called the widowmaker. Why do you think it's called the widowmaker? Because it usually kills folks. Because the left anterior descending feeds the front of the heart. The left circumflex feeds the whole left side of the heart. That whole tissue will die if the left main is compromised. So the left main splits and goes down the front of the heart, making the left anterior front descending because it comes down, descends. The left circumflex is on the left side of the heart, and it circumference, it wraps around the left side of the heart. Now, a lot of us have, actually all of us have a different coronary circulatory anatomy. These are the main guys you need to know about because there are other branches such as, let's say, the right ventricular branch, atrial branch, sinus node branch, posterior descending branch, left ventricular branch. But the problem is that you may have this one, this one, this one, and not have that one, that one, that one. And then you will have this one, this one, this one, and not have that one, that one, that one, because not all branches are present in all people. Think about the veins in your arm right now. You've all started an IV before, right? Has everybody's vascular system been the same? Or is it different and in different places and all over the place, right? That's the same way your heart's coronary system is set up. Not everybody has all these going on. But what you all do have is the right coronary, left main, left anterior descending, and left circumflex. What also you have is that different portions of your heart are fed by different arteries. Majority of the population is right coronary artery dominant, which means that he runs the show for most of the heart. He feeds the conduction system and the majority of the heart. There's also a population that's part of the population that is co-dominant, where both of the sides of the heart arteries are feeding everything and kind of sharing the load. Then by process of elimination, you've probably figured out there's also people that are left coronary dominant. That's a good question. He asked, how does that help you if we respond to calls? So when we're looking at an EKG and we take a look at the leads, we're only going to look at the heart from a few different angles. We call it a 12 lead, right? So we're looking at the inferior portion of the heart, which is fed by the right coronary artery. We're looking at the septal portion of the heart, which is fed by the left anterior descending part of the artery. We're looking at the anterior portion of the heart, the front, the lateral portion of the heart. We're looking at the heart in different angles, and one of these arteries will be feeding that area with the occasional posterior artery involved. So when you're looking at a 12 lead, you're looking at which artery is involved. Is it the right coronary, left anterior descending, or left circumflex, or a combination of them? We have an MI that's isolated. We have some that are transmural, where the entire myocardium is being compromised. But part of seeing a patient with ST elevation is noticing the presence of an infarct and the location. I'll give you an example. A patient experiencing ST elevation in leads 2, 3, and ABF is experiencing an inferior myocardial infarction, meaning that the inferior portion of their heart is being affected, and that means the right coronary artery is the guy with the blockage. And we're not there yet. We'll be there in a couple weeks. But just as a preamble, because you asked the question, is that's what I'm looking for, is which artery is involved. Because based on the artery involved, I may withhold certain treatment. An example would be an inferior MI. We have traditionally withheld nitroglycerin because the inferior MI has a lot to do with the patient's preload. And if I give that patient nitro, I'll bottom their pressure out and they won't be able to feed themselves anymore. That precipitous drop in blood pressure may kill them. This is why I prefer a 12 lead before I gave any nitro, an IV before I gave any nitro, a history before I gave any nitro, because I know that this is a different type of MI that I might want to withhold a certain medication from, or at least begin a bolus to increase preload before I give it. That makes sense? Very good. That left main. I bring the left main up only because he is a big guy. He's the widowmaker. He's the largest and shortest. Now, what do I mean by largest? And shortest. So his diameter, he's thicker, bigger, wider. Hey. But he is shorter because when he splits, he makes LAD and left circumflex. Now, what about the composition of your blood? We said you had to have a strong pump, intact pipes, enough volume, but there has to be enough stuff in the volume, right? So about 55% of your blood volume is made of plasma. Plasma being this either clear or straw colored fluid that contains the components of such as albumin, where the medications you give a patient can attach and circulate to. Plasma being the what? The fluid component of your blood. 45% of your blood volume is red blood cells, whose job is what? To carry oxygen. And then you have less than 1% being what? White blood cells, platelets. What's another name for white blood cells? Leukocytes. Their job is to do what? Fight infection. Another name for red blood cells is what? Erythrocytes. Their job is to carry oxygen. Another name for platelets is what? Thrombocytes. Their job is to help with the formation of clots. So your blood has to carry oxygen and nutrients to tissues. Remember our little cell diagram? Needs three basic things: water, oxygen, glucose. The job of your circulatory system is to transport that to the tissues that need it. And then, as your cells go through their glycolysis and cellular respiration, there's a waste product created. CO2, amongst other things, has to be gotten rid of. You can't have trash in your system, right? We have to get rid of that CO2. It is acidic. It is damaging. It will drop the pH in my body. So my blood has to carry the CO2 away. Just a quick recap on red blood cells. They're erythrocytes. Process in which they're made is called erythropoiesis. Erythrocytes have a lifespan of about 120 days. After that, they wind up in the spleen, where they are deconstructed and destroyed. White blood cells are known as leukocytes. We said they fight disease. There's two types of them: granulocytes and agranulocytes. Platelets, we said, was what? Thrombocytes. They're essential for clot formation. Clot formation. All right, so the cardiac cycle begins with preload. You have to load it before you can shoot it off, right? So we preload. We have blood returning back to the right side of the heart. It fills the ventricles at the end of diastole. And then with your stroke volume, your ejection fraction, which is expressed as a percentage, we eject blood via the left ventricle. And that pressure exerted against the arterial walls is where we get our systolic blood pressure from. Our systolic blood pressure is the force exerted against the arterial walls, and the pressure left inside the ventricles after that contraction is our diastolic. How much pressure is inside the heart? Now, we said Starling's law was a rule that gave us a guideline of that. The more the muscle is stretched, the harder it's going to hit. Quick example is the rubber band man, right? You pull it back farther, it's going to hit harder, right? So afterload is another term we have to knock down. This is the resistance in which the ventricle must contract against. The resistance in which the ventricle must contract against. Now, the cardiac cycle is an important component to understanding how a patient's metabolism and perfusion needs work. They have got to have an adequate cardiac output. When I put my hands on a patient's wrist and feel for a pulse, I'm not just doing it for the fun of it. I'm not just doing it to get a numeric number or metric. I do want to know if their heart rate's between 60 and 100. I do want to know that, because then I can determine if they're bradycardic, tachycardic, or if they're irregular. What I'm also trying to determine is, are they thready, normal, or bounding? I can tell their mechanical output based on how their pulse feels. If it's thready, the heart is weak, and it may have been decompensated. If it is bounding, the heart is struggling against something. Now, it might be just that I look good. Heart rate might have went up, bang, bang. But more than likely, it's because their body's in a stress response, right? I know the uniform does a lot for me, but it's more likely that the heart's under stress of some sort. What will a patient who is in compensated shocks heartbeat feel like against your fingers? Bounding and pounding. I am working. I am working. Now I'm and say, oh, I'm tired. Thready. Butterfly wings. Thready. Butterfly wings. Nothing. You can tell where they're at by the pulse field. How many of us are seeing our medics out there not even putting their hands on a patient? Feeling skin color, temperature, moisture, looking at it as an actual vital sign. Isn't that diagnostic data going to push you in some direction or not? How about this? Patient's pale, cool, clammy. You think shock. Patient has a red rash and hives. Red rash and hives. You're going in another direction. Patient's in a nursing home and has hot skin, febrile even. You're going a whole nother direction. But if you're not putting your hands on your patients, you're not getting that data. Now, cardiac output varies from person to person, and that varies based on activity, need, position. Would you like an example? Let's say we take Woody, hi Woody, and we say, sitting there, he's just like, the blood pressure's probably like a nice 120/70. Heart rate's probably a good 65, 70. He's in good shape, right? We're going to take him out into the bay and make him run up them stairs until I get tired. What do you think his blood pressure will be once he starts doing them stairs? Significantly more. What do you think his heart rate will be? Significantly more. Because it's based on activity. Even just sitting there versus standing there, your body requires a different pressure. Your cardiac output changes and auto-regulates based on barometric pressure changes it senses it needs, based on your receptor's perception of need. Inadequate cardiac output can be caused by CHF because you've lost ventricular stretch, and MI because you've lost tissue. It's now dead. Does dead meat beat? No, I'll play it. It don't. Or shock, a hypoperfused state, meaning that the patient is not able to meet the demands of their body. Your job as a paramedic is to find out what type of shock and aggressively treat it. Some things you might see. Shortness of breath. How do I know that they have compromised cardiac output based on shortness of breath? What does that mean? They may not have enough blood flow to their lungs. Dizziness. There may not be enough blood flow to the brain. Chest pain. They're not feeding their self. They're not feeding the heart. Blood pressure is dropping, cardiac output's down. Cool and clammy skin. These are signs of shock, but also decreased, compromised cardiac output. My needs are not being met. Again, this is how I tell if a patient is stable hemodynamically or not. When we get to arrhythmias later, this will make more sense. patient has got a heart rate of 200 and they're just sitting there talking to you, but they feel like a little weak and dizzy, they're pretty stable, right? But if they're sitting there, they're in and out of consciousness, they're dizzy, they're having chest pain, the blood pressure is low, they got pale, cool, clammy skin, they're not able to meet the demands of their body. Their brain, their heart, their lungs are going without, and they're showing you symptomatic changes. That are occurring based on that. Now, the body does have a backup system. The body can exert some sympathomimetic or parasympathomimetic control over the heart through your autonomic nervous system. Your autonomic nervous system is meant to regulate the heart, to put it in the direction it wants to go. Stressful situations have the sympathetic nervous system working and dominating. During rest and digest and feed and breathe, you have the parasympathetic nervous system, which is going to take dominance based on the extrinsic factors you're facing. If Fan was to come in here one day with a gun saying, screw all of you, with his trench coat on, we would all probably have a sympathetic response and dump adrenaline. But after lunch, I'm sure we'll all be going to the bathroom because we're having a parasympathetic dominance of that rest and digesting, right? You'll get sleepy and tired. Sleepy and tired based on the sensing of these factors. So what does a normal look like? The sympathetic nervous system is going to rev you up, prepares you to fight, take flight, or freeze. Fight, flight, freeze, or faint. You ever heard of playing possum? They sit there and play dead. That's actually not a thing that can help. Once they play dead, they've actually froze. Their sympathetic nervous system has froze them. It takes them about 20, 30 minutes for them to unlock down. So you rev up, you freeze, you take flight, and your heart beats faster. Your breath is faster. Your pupils expand so you can be more sensitive to light to let more things in. Your gut becomes inactive. Blood rushes to your skeletal muscles. Why? Say it again. They're constricted. Okay, very good. And I want to send blood to my muscles. I got to need them. I got to fight or flight or run, right? I need them there. Blood rushes away from your brain so you don't think as clearly. This is why you must train your body. Muscle memory. Because all of us can get a little freaked out on scene, right? It's okay. It's okay. Even I still get butterflies. Pediatric arrest comes out, butterflies will happen for me, for you. But I have to take a step back, detach, analyze, prioritize, then execute my maneuvers 1, 2, 3, 4, and move that way. Do the next right thing. And I promise you, slow is smooth. Smooth will be fast. It's all about following the steps to the dance. So it helps you expend your energy, but is there a finite amount of resources? We're going to run out of gas eventually, right? You ain't got so much epinephrine or adrenaline, right? Now about the parasympathetic nervous system, the relaxation calms you down, prepares you to rest, to think, restore. Heartbeat slows. Breath is full and slow. Pupils shrink. The gut becomes active to help you absorb nutrients. Hormones rush in, lifting your mood, help you conserve energy. You know why a lot of you are tired all the time, and no matter how much sleep you get? You're not actually resting because you never actually restore and rest and rebalance. Think about it. Who worked last night? Engine what? Engine what? 36. You slept all night. I don't want to hear a thing from you. Well, let's say engine 9, who was probably up all night, you know, they get a call, adrenaline dumps, especially like smoke showing, right? Ooh, Job town, boys, let's go. Right? Let's say you get that, then pediatric arrest, then 3-car pile up. This is your day, bang, to bang, to bang, to bang, dumping, dumping, dumping. Then you go try and lay down. I don't know about you, but even when I sleep at the fire station or the EMS station, it ain't a real sleep because I'm always like a bit anxious that little pager is going to go off or the tones will drop. It's never a restful sleep. Then I'm up all night, right? I never actually have time to regulate my mood. Then you go home and you got to do other things, right? I got grass to cut, babies to rock. No wonder I get home and I don't want to talk too much, right? I want you to recognize these signs and symptoms that burnout is a real thing. And you have to force yourself, literally force yourself to go back to what the heart taught us initially was what? Feed yourself first. I can't be a good father unless I've taken care of myself. I can't be a good husband unless I'm taking care of myself. I can try. I know a lot of you have ran this thing on the red line, but it's harder. And eventually you will hit a wall. You will hit a wall. So if you love your wife, take time for yourself, get that workout in, you know, do the things that you enjoy. It's not selfish. I apologize for breaking off into this rabbit trail, but I feel led to tell you that because then it's a very big problem for all of us. Matter of fact, the paramedic student was texting me last night or messaging me last night. Their program's about to end, and this student is phenomenally talented, very smart, does the right thing, has been one of my best students I've ever had. But here at the end, she's tired. Understandably so. She sounds like every other paramedic student I've had since 2012. That's how she feels. She's juggling all these things, but here's what the good news is. The finish line's right there, and this too shall pass. And you will regulate your nervous system. You will get back to a place where you have rested and you will have accomplished your goal. And it is so sweet. The you now versus the you the day after paramedic school is a night and day person. We had a girl in here that was in the 22 class who had spent 3 years in med school. Phenomenally smart. And I kind of told you jokingly that we had a personality change, right? In that individual, because just the stress levels. You have to manage this. You have to juggle it. Take the advice from the old bear here. Take some time for yourself and make sure you're putting yourself and your family and your fate first. That way you can do this properly. Because you can try, but you're not performing optimally. You're giving a half effort. So how does these nervous systems exert control over the heart and then their body? Hormones. Hell yeah. Based on the need, it releases certain chemicals. Alpha, beta 1, beta 2. Let's take a look. So beta 1, you've got one heart. The beta 1 receptors are located in the heart. They adjust heart rate, stroke volume. Heart rate, stroke volume. Meaning they make the heart beat faster, harder, and they increase the rate of impulse conduction. Cardiac conduction velocity is faster. Beta 2, 2 lungs. You got 2 lungs. Beta 2 receptors are located in the lungs. They increase Bronchodilation allow more fuel in, more oxygen. Alpha arteries, AA, are located in the arteries. Alpha receptors, A1, is in the arteries. By activating them, we can have constriction and we can have an increase in blood pressure. You carry drugs that are bioidentical to these hormones. You carry epinephrine, you carry norepinephrine, you carry beta 1 and beta 2 stimulators. Based on what that patient's got going on, you can influence this patient's body to move in a direction that you want it to go. Apologize for my voice. I was actually sick last week. I wasn't playing. I was coughing up green stuff and had 103 fever. But through the miracle of drugs and hate and caffeine, I'm back. So here's just another little chart of what you're looking for, what's happening there. Chronotropy, dromotropy, inotropy. Chronos, rate, is time. Where does that stimulation occur? It occurs in the SA node. Through a sympathetic tone, makes the heart faster. Dromotropy, conduction velocity, occurs at the AV node. It sends signals faster. And inotropy, that miracle occurs where? In the ventricles, because work on contractility is increased. How does the heart make my contractility increase? Think about the rubber band, man. Pull back farther, hit harder. Ooh, this hand sanitizer smells like tequila. What is like cologne? What you got? This is sympathetic nervous system. Yes, sir. And how does it do that? It's because the heart is an endocrine organ as well as a mechanical pump. The heart is an endocrine organ. In times of stress, it releases hormones. The greater the stress, the greater secretion. Think about it. I said earlier, the only way you really know somebody's having a heart attack is to test what? Blood levels. Troponin levels ain't gonna rise unless the heart's got dead and dying tissue. It'll release those chemicals as a sign that it's in distress. The heart also releases atrial natriuretic peptide and brain natriuretic peptide. When the heart is in distress and a patient's had, let's say, an MI, they've got dead and dying tissue, the heart will release this chemical, BMP, to cause the heart to stretch farther to compensate for the fact that it's got dead tissue now. You know how they diagnose CHF? They run BNP levels. If they got a BNP that's ran up over 400, that's CHF all day. That's how somebody's diagnosed it. Because it's a tall tale sign, right? If they have loose, baggy ventricles, it's because their body's released BNP, secondary to a possible MI or other causes like cardiomyopathy. Think about your crackhead. Your heart ain't meant to beat 250 times a minute for a couple days there, fan. Cut the crack. Walter White. So how do we diagnose it? We see a congestive heart failure forming secondary to a drug introduction or NMI. Does the dead meat beat? No, it does not. But the heart, being a very smart organ and an endocrine organ, will release these chemicals to compensate. What does it mean to compensate? Isaac, at your age, can't do it anymore, so you have to have a little help, right? There you go. Cialis is hell on earth. So the body will make adjustments, but like any compensatory mechanism, it does have a finite amount of resources. Finite amount of resources. Meaning that it will run out of juice eventually. What you got? All right, let me do it one more time. Or as many times as you need. Patient's had a heart attack. They've got dead tissue here. Dead meat don't beat. So to achieve the same amount of cardiac output that I was hitting without this tissue over here working, it's dead, it don't work. My body, the heart will release brain natriuretic peptide that relaxes the ventricles and allow them to stretch farther and harder. Now, this allows me to achieve the cardiac output I need, but it also makes my heart baggier and looser. And all right, fan. Baggy and looser. Figured I'd ask him about it. He knew about it. It's really about the ventricles, yes. So because it's baggier and looser, it's trying to meet the needs of the body, but because it's baggier and looser, it doesn't have that same collapsal contraction power. So some of the blood sometimes doesn't get ejected out and it backs up into the lungs. That's where we see the CHF causing pulmonary edema. Cardiomyopathy over time. Over time, the heart gets baggier, looser, loses more elasticity, and it's not able to compensate over time. Eventually, it's a terminal diagnosis unless they have an LVAD, intra-aortic balloon pump, or a heart transplant. Yes. The most common cause of CHF is a heart attack, but there's other causes of it. Hypertension over a long period of time can cause it. Eventually, yeah, it can cause cor pulmonale. Also, somebody with left ventricular hypertrophy secondary to hypertension will have a bigger, baggier heart because that left ventricle has enlarged over time. I like it. Well, folks, but you can live through that, right? You can live through Atlanta Chinese food. You can live with a broken ankle, but if the heart ain't hearting, there's a problem. Okay? So we talked about cardiac output and its portrayal and how we have to understand it so we can effectively treat the heart. And I don't want to freak you out with all these terms, but literally, if the heart is not beating, beat for it. If it's too slow, speed it up. If it's too fast, slow it down. Now, we have many techniques available to us to make this happen, but understanding that at the end of the day, it is a simple mechanical issue. There's not enough fluid in the tank, put some in there. Everybody here drives a car with gas in there, right? Or half a tank, quarter tank. Towards the E, right? What happens? You're going to fill it back up. If the volume is low, put it back. So there are certain electrolytes that affect cardiac function. Things such as sodium, calcium, potassium, chloride, and magnesium. Thank you, Kim K. So sodium has a job to do. Depolarizing the myocardium. Cardiac depolarization occurs when that sodium potassium pump has sodium leak into this heart cell. And once it leaks in there enough, electricity will cause the sodium channel to open fully. And then we'll have what you can attribute kind of like to flashover. Oxygen rushes into a room, explosion of energy, right? When sodium rushes into the cell, explosion of energy. Calcium is responsible for myocardial depolarization and myocardial contraction. When you think of calcium, think contraction. We can just keep it that simple. It assists with depolarization but it also is mainly there for contraction. Pretty good. Potassium influences repolarization. Potassium is repolarization. So let's go back. Sodium, responsible for depolarization. Calcium assists with depolarization, but is mainly responsible for contraction. And potassium is repolarization. Now, there's a lot of nuances and details to that we'll get into in a little bit. But right now, you can lock down potassium, repol, calcium, contractility, sodium, depolarization. We're in pretty good shape. So bioelectricity is created by the movement of these ions through a semi-permeable membrane. This is a test question I saw April 2020 when I retook the National Registry test again. The main extracellular ion is sodium. Main intracellular ion, potassium. Movement of those two ions through that cell membrane is what generates electricity, giving the heart its ability to generate electricity and have automaticity. Auto meaning self, maticity meaning electricity. It is through this sodium potassium pump that we create electricity. Now, cardiac muscle cells and tissue is all excitable and conductive. All of it is excitable, meaning it can be stimulated, and conductive, meaning it can transfer that electrical signal. Through the use of intercalated discs, these cardiac muscle fibers can conduct electrical impulses quickly. And through the use of the syncytium, where one cell becomes excited, and that action potential or electrical impulse spreads across the entire group of cells in a coordinated contraction. Now, what does that mean? Has everybody seen the wave at a sporting event? Has anybody ever seen somebody just stop the wave by not participating? That is what will happen in the heart. Either it's an all or nothing phenomenon. So once one cell becomes excited, that action potential, another word for action potential is electrical impulse, it travels through the rest of the myocardium doing the wave. And either they will all participate or none of them will. All or nothing phenomenon. Now, these myocardial cells are responsible for having four characteristics: automaticity, excitability, conductivity, and contractility. You have autoarrhythmic cells, and then you have contractile cells. Autoarrhythmic cells and contractile cells. Basically, your autoarrhythmic cells are located in pacemakers. Nodes or bundles of these pacemaker cells that generate electricity. Their job is for that electrical impulse to travel through the muscular tissue to get to contractile cells that will allow them to do what? Contract. Now, myocardial working cells are both contraction and relaxation capable. The physical contraction of myocardial tissue actually generates blood flow. Let's take a look. Heart stimulates. If I was to tase you, what would happen? You would move and jerk, right? The heart ain't gonna move until electricity does, right? Electricity stimulates the heart, causes a movement, contract, movement, contract. It literally causes it to spread apart and then collapse upon itself, pushing blood out. Those are your working cells. Those are your contractile cells doing that. Now, the specialized pacemaker cells don't have the ability to contract. They simply are there for controlling rate and rhythm by coordinating a regular, steady electrical depolarization. And they have a pacemaker system, a conduction system that is in an insulated place. What does it mean to be insulated? Insulated and isolated. They're in a protective cocoon. They're in a protective cocoon within the heart, but separate from it. That is so that they cannot be that easily stimulated to take a bump in the chest and interrupt the conduction. There is a place in your myocardial electrical output where that can't happen. In the myocardial electrical graphical reading of an EKG, there exists a place called the relative refractory period, where an outside stimuli can cause an interruption of your electrical pulse, pulsatile flow. This is where you hear about things like commotio cordis, like a ball hits a kid in the chest and it caused their heart to stop. But for the most part, it is a insulated, isolated, protected conduction system. Pacemaker cells are to generate and conduct electrical impulses. They have the ability to create that electrical impulse without being stimulated by a nerve. That means that the central nervous system does not exert control over the heart. It creates its own electrical impulses via that sodium-potassium pump. Now, another term you want to write down and learn is threshold. That is the point in which stimulus will produce a cell response. Threshold is the point in which a stimulus will produce a cell response. So with that, again, we have the cell up here. We've got like, let's say -90 going on down here. That is where the electrical point is. Now this sodium channel over here does what? He leaks. So this -90 is slowly climbing up. Threshold's the point when that electrical capacity is hit, that all the electrical voltage gated ion channels, like the sodium channel, is gated. It means it lives in a gated community. But a certain voltage will open that gate. Once threshold is that voltage, once that voltage is hit, sodium channels open wide open. Then sodium does what? Causes the myocardial pacemaker cell to depolarize, opening the calcium and potassium channels. What you got?
Pacemaker cells.
Yes, sir. Yes, sir.
How does that happen? Because the cranial nerve, that's right?
Cranial nerves. Cranial nerves do send nervous signals to skeletal muscle tissues and to other voluntary functions. But the heart is its own entity where it doesn't require any central nervous system stimulation and doesn't have any influence by it. If the brain wants to influence the heart, it uses the autonomic nervous system through neurotransmitters to transmit that signal. So if the brain is sensing that, hey, I'm going into shock, I don't have enough blood in me because I was stabbed by Josh for failing a test, the brain will then signal the body to release epinephrine, which is a neurotransmitter, which will cause the heart to beat harder and faster. That's how the brain exerts control through hormones. That make sense? The rest of your body parts are controlled by the brain, by my choices, right? By it sending a signal. I can't do that with my heart.
If heart does its own thing, I'll actually might say.
That's it. What you got? Sodium rushes in, potassium rushes out, calcium rushes in. And that's depolarization. And then when repolarization occurs, it all goes back to ground zero, level one. Sodium rushes out, potassium rushes in, calcium rushes back out. Here again is a list of the primary characteristics of myocardial cardiac cells. Contractility, meaning mechanical function. Automaticity, which is electrical function. Excitability. Conductivity, which is again electrical function, meaning it is capable of sending the signal elsewhere. And there's your little chart to help you remember it. Also, I made this PowerPoint for you. If you have a jump drive, you can have it. If I can figure out a way to send it, I might can do it via Dropbox. I don't know. Let me see if I can play with it. But I've got to get it in your hands. So the conduction system starts with the SA node. SA node being the dominant pacemaker of the heart, generating the impulse and trying to pace the heart at a rate that is sustainable for meeting the metabolic demand of the body. So anything between 60 and 100 is considered normal, right? What if old shoeless Joe over here has a normal heart rate of like 94? Well, that's what it takes for his heart to meet the demands of his body. He may be older. He may be a smoker. He may have, you know, some other issues that mean that he has to require his heart to beat a little harder than yours to meet the demands of your body. Let's take a look. So normal beating of the heart is at 60 to 100 here with the SA node. But there is a system of succession. If the king dies, there is going to be someone to take his place. If the SA node can't cut the cheese, atrial cells and the AV node will begin to take over. If they fail, the bundle of his will take over. Bundle branches after that, then Purkinje fibers, and at the very bottom of that is myocardial cells at the bottom of the ventricle. While they are not beating at an ideal rate, they can beat. And something is better than nothing. Patient has a heart rate of 30, showing an idioventricular rhythm on the EKG. That is something. They got a pulse, they got an idioventricular rhythm. You can work with that. You can speed it up somehow. Pharmacology. So medicine versus Edison, either by pharmacology or electricity. So let me ask you a question real quick. How hard do you work at work? And how hard are you working in paramedic school? Some of you, I can tell you, are mailing it in. Some of you are busting that can, but some of you are just existing. Are you surviving or thriving? So my question is the effort you're giving, would it be enough to save your life if somebody had the reverse situation? The question is posed. If a surgeon is working on you and they're going to give the same effort you give at the firehouse or in school every day, would you live or die? That's the question. You'd be deader in hell. Some of you might be all right. Some of you might not be all right. I have these pause breaks to remind you what you're training for and what you're studying for. The quality of your care will determine the quality of the patient's life. Your ability to recognize a stroke can determine if that patient walks out of the ER or leaves with a left-sided deficit. Just a quick reminder of what's at stake here. We said the SA node is located in the upper right portion of the heart in the right atrial wall. Primary pacemaker of the heart, it's going to be the king of the castle. Now, beyond that, the SA node has to send signals to the AV node through intranodal pathways. So let's talk about that. SA node is a node. AV node is a node. There has to be internodal pathways that receive and transmit signals. These intranodal pathways are what the SA node uses to send the signal to the AV node. Now, the AV node actually is the gatekeeper. He's on the floor of the right atrium, right above the tricuspid valve. He delays electrical activity for about 0.05 of a second to allow the ventricles more time to fill. That way, the ventricles have time to actually put out a better product, a more complete product, because it has had more time to fill. The AV junction is the role or the goal between the top and the bottom. It can pace the heart and create junctional rhythms, which we'll cover soon. Now, the bundle of His is a conduction pathway that leads out of the AV node, receives blood from anterior and posterior arteries, lies at the top of the intraventricular septum. So the bundle of His is at the top of that septum, dividing left and right. When we talk about bundle branches, left bundle branch, right bundle branch, at the top of this guy is the bundle of His. The septum is what goes left and right. The bundle branches go left, then right. So we have SA, AV, bundle of His, then bundle branches go into the ventricles, splitting left and right. And they are innervating that left and right ventricular tissue. Now, the bundle branches divide into two main bundles. Right bundle? You still making notes? All right, I'll give you a second. Got a lot going on, I understand. If I'm split it. There we go. Now, the bundle branches are when that split occurs. So we got the right bundle and left bundle, and I'll teach you how to recognize bundle branch blocks later once we start EKG, arrhythmia recognition and analysis. But they conduct electrical activity to the ventricles themselves. Again, SA, AV, bundle of His, at the top of that intraventricular septum. Then the septum is the piece of tissue that divides the left and right ventricles, right? Now, in those, we have a split occur as these tendril fibers go into the left side and the right side, again, innervating that tissue. Bundle branches then fire off into the Purkinje fibers, which are these, again, fibrous little tissues that are in the ventricles, innervating them. Yes, sir, come on.
Yeah, that's a conflict. So how does it get back to me?
So let me see if I can understand the question. So what we have here is a heart, all right? Terribly drawn. SA node sits up here. He wants to send the AB node a signal down here. Bundle of his here. Bundle branches here and here. At the bottom, we got Purkinje fibers over here. So as that signal travels from SA node to AB node, the AB node will hold the impulse for just a 0.05 of a second, or whatever your own body heart does. And then the bundle of his, if it has to, if the SA node and the AB node and the atria are no longer able to pace the heart, it will generate its own impulse and pace the heart. But the problem is its intrinsic rate, its ability to pace the heart is slower. So like me and Fan here, my ability to speak clear and articulated sentences is at this speed. His, because he's a fireman, is at a slower, less proficient speed. So he could try, but he can't do like I do.
My question is, so, you know, the assessment pathway,
Yes, sir.
so the MD node, the people with the assessment pathway, the MD node still works at the same time, like the assessment pathway.
It depends on where that impulse is generating from. The AV node is the logical choice for the next line of succession, unless the AV node tissue is diseased, dying, hypoxic, ischemic, which is the same thing, I guess. And if it is not able to generate the impulse, somebody else will take up the mantle.
I guess,
Ask your questions. Now's the time. I will stop the show for you. Today's your day.
So the assessment pathway, and people with, so they don't have the AD, but they have the assessment.
I see. So the normal conduction system flows like it flows, but people that have like Wolff, Parkinson, White, they're born with an extra accessory pathway system through the bundle of Kent. So basically they have a back domain.
But they don't have the AD.
They have an AV node, they do. But what that accessory pathway does is it goes around the AV node. It's a back door that can sometimes take over the heart's own beating. Does that make sense?
But so how is that, like when they back, but not the AD, but so when it goes around, it connects back to the,
So if the accessory pathway such as Wolff, Parkinson, White is running the show, he's easily identifiable by his slurred Q wave, his widened QRS, and his shortened PR interval. It looks like a delta tailwing. And if he's running the show through that accessory pathway, he's controlling the speed in which the conduction velocity is flowing through the rest of those systems. So if he's flowing around the AV node and shooting it to the bundle of his, he's controlling the speed of what the heart's going to beat at. He's sending that signal and they just have to receive it. So if you're not sending the signal, what's that?
the delay to the same, 0.25 seconds.
There's no delay. That's the danger of a Wolff, Parkinson, White, is that it can cause a rebound tachycardia where the gatekeeper, AV node, is eliminated. This is why we teach y'all not to give adenosine to Wolff, Parkinson, White, because you eliminate the gatekeeper. Because he's normally doing a good job of buffering and keeping that heart rate from running too high. You give a Wolff, Parkinson, White like an adenosine or something like that, you've eliminated gatekeeper, and now that bundle of his and bundle branches and all that are going to be stimulated at a much faster rate based on that Wolff, Parkinson, White syndrome's rebound tachycardia. I like the questions, I do, but you're living in June 28th of 2024, and we're here at what's today's date? We're at June 24th. But the question I see, you're trying to understand the conduction system and its flow, right? So the flow, let's keep it simple. SA node wants to generate an impulse, send it down the chain. The rest of the guys are just catching and throwing, catching and receiving. Unless SA node dies, he's no longer the king. Somebody's got to run the kingdom or the body dies, right? So to compensate for this problem, If that happens, either the atrial tissue or the AV nodal tissue or the bundle branch tissue or some of that tissue is going to kick in and try and pace the heart. The problem is, again, it doesn't have the same capability as the SA node. It doesn't have the speed and power. But it's trying to prevent a cardiac standstill. I think Fan was next, and then I'll get you, Mitchell. What you got? Very good. A slow reperfusion rhythm, yeah. So if you've ever gotten a Ross back on a patient, sometimes you get a very slow, wide, complex rhythm because at that point, a lot of the myocardial cells have been down very long time and they're dead. And those Kenji fibers and those other slower ones, they're the last to hang on, so they come back first. So that's why we have a reperfusion rhythms look a lot like that. Mitchell? I can't hear you. Okay, so they answered yours too? Very good. So his question was, if another pacemaker takes over for the dominant pacemakers and its intrinsic rate is slower, can our intervention still make a difference? And the answer is yes. If your pacemaker is too slow, I will apply a transcutaneous pacemaker and take over for the heart. If that's not effective, because again, let's face it, the reason this guy's in heart failure, the reason this guy's pacemakers are not working is because he has dead tissue. That means it's not going to conduct through it. I have pharmacology now where I can throw drugs at this thing and make it beat harder and faster. Now, at a certain point, though, Mitchell, if there's too much dead tissue, there ain't much I can do other than CPR. And I can act as a mechanical artificial pump for the patient, but unless there's some kind of surgical intervention, there might not be much we can do because at a certain point, the tissue's been down too long and it doesn't have the cardiac excitability, conductivity, or even contractility anymore. So this is why it's important to run our codes with capnography to see what the viability of these cells are. And that's why it's important to keep the patient on oxygen and keep blood flowing and going. I like it. Anybody else? Groovy. Let's put it all together. Here is a review system of all that. The SA node, its firing rate, running 60 to 100. Intranodal pathways are transferring that impulse from SA node to AV nodal tissue. The AV junction, AV node, and bundle of his, they're slower. They fire it at 40 to 60 beats a minute, which again, is better than nothing, right? But it's not always ideal for having optimal life functions, right? This is your patient that might experience a loss of mentation. The blood pressure is dropping. They're having trouble breathing, or they're pale, cool, clammy because they have poor perfusion based on their rate. Because cardiac output is what? Heart rate times stroke volume. The heart may have a good stroke volume, but if the rate's not enough to meet the demands of the body, you will see some symptomatic bradycardia issues. Questions about that? All right. Let's close with this if I can get it over there for you. Let's do another look at this sodium potassium pump, okay? That is a cell. The cell sits in a polarized state. inside the cell, what ion is running the show? K. That's kind of a K, right? Outside the cell, we got two intracellular, extracellular ions that are trying to get in. Very good. I got sodium. Calcium. There's your potassium channel. So again, this pump to create electricity works off of bioelectricity created by these ions shifting because they're cations, they're positively charged. Now we start down here where? At -90. And again, at -90, these are voltage gated, meaning what? They are closed, can't get in. But again, sodium channels leak. Remember, he's the back door man. You're off on deployment. And this is Jody sneaking in to get your wife. So it's whether you're on deployment overseas or you're on your tour of duty for your 24-hour shift. Jody's coming over. So here he is. Right? So sodium channels leak. I hate to tell you, but Jody probably leaks too if he's coming over into the back door. So as Jody leaks, what happens to this -90? Start to come up. At what point does the door wide open? It's called threshold. Once that sodium channel leaks enough to the internal voltage of this cell reaches above -90 to threshold, the sodium channels bust wide open. So sodium channels are now open. Sodium's rushing in. So potassium, what's it gonna do? You coming home from deployment? Baby, I'm home. What's she gonna do? She's gonna run, fly the coop. You got that crazy look in your eye again. So sodium is rushing in, potassium's rushing out. And then who are you? Calcium. Calcium's running in to see what's up. Hey, baby, how you been? Only thing I see in here is sodium. So what we have is sodium rushes in, causes a big spike of electricity. And then potassium runs out. Now we have a plateau phase. That's when sodium and calcium are having a standoff. We're at a plateau phase. But of course, you being the righteous man, have that strap on you. So what happens is we got to go back to the way things were. Sodium better get up out my house, right? So sodium rushes out. Calcium rushes back out. You got to go back to work. And what does potassium do? She comes back in the house full of forgiveness, I'm sure, and regret. So this is your sodium potassium pump. This is the look that you're going to have. That is what's going to occur. Say that again. Most people's own intrinsic rate will determine that, because ours might be a little different. When we give you numbers, Jesus. When we give you these numbers, they're based on norms that were based off of the research done on a bunch of select group of people. You know what I'm saying? It's not always accurate. Your normal firing rate might be a bit different. We said your conduction system and your circulatory system in your heart, those coronary arteries, they're all different for everybody, right? So the standard is what we've said is that there's a delay of 0.05 in the AV node, that this is what should happen here. But keep your mind open for the ability for the atypical presentation, because I've seen more atypical presentations than I have seen people fit into the mold. That makes sense? I've already covered all that. So how does that sodium potassium pump correlate to you? Well, it directly impacts your EKG. Because we said what? Phase 0 here was going to do what to me? That's where sodium's rushing in or leaking in. We hit threshold, we got a big spike of electricity. That big spike of electricity is what's creating your ventricular depolarization or your ventricular pumping. That's what's making your contraction. Your P wave there stands for and represents atrial depolarization. That plateau phase is right here where that contraction's occurring. And then this T right here, this other little bump behind it, represents ventricular repolarization, or where everything's going back to normal, where everything's going back to level 0. We have sodium rushing back out, potassium rushing back in, calcium rushing out, and that resets that phase there. Resets the phase there. So